Hello, my name is Kevin Twardus, and I'm the CEO of Cloud9Data, and I'm here today with my good friend, Dr. Evert Imkamp. He is a board-certified physician, and we're going to talk to you today about AI and all the wonderful things that you all want to know about medicine and how AI will give you better outcomes and better healthcare than you might be experiencing at the moment. As most of you know, or maybe you don't know, healthcare in the United States is in a little bit of a crisis. We're having lots and lots of issues like never before with chronic disease, and statistics and people are reporting that their satisfaction is lower than ever with the United States healthcare system. So we're paying more, getting less, and our outcomes aren't necessarily great. We don't rank among the top 3 for healthcare in the world, which is a pretty depressing statistic. So without further ado, Evert, how are you today?
Oh, pretty good. Thanks for inviting me, Kevin.
Feeling healthy?
Feeling pretty healthy. We'll go into my personal trial.
Your personal health journey?
Personal health training.
So today I want you to tell us a little bit about yourself. You know, you're a Washington resident. You weren't necessarily born here, but you spent most of your formative years here.
Yeah, the first 10 years were spent overseas, where I was born in the Netherlands, also Holland. And parents immigrated back in the late 50s to Eastern Washington, and went to school in Spokane and small town in Eastern Washington, and finally moved to Seattle, went to University of Washington, got my degree there, and then decided to go into medicine, and went back actually to my home country, to the Netherlands and Leiden, where my dad also went to medical school, and did my medicine there. Then came back in 1980 to the United States and did residencies in family medicine and radiology in Michigan and Colorado, and then practiced radiology for most of my life, and then came back to Washington for good in '88,
and been here ever since.
Been here ever since.
Wonderful.
Seem to love it.
Wonderful. So another thing that we want to do today is cover kind of a broad range of topics, but with the objective of getting to some conclusions around how do we get AI in a much more personalized, responsive, adaptive manner. How do I get AI my way? How do you get AI your way? So we're going to look at diagnostics and imaging. We're going to spend some time on analytics, prediction of your potential ailments, prediction of your outcome. We're going to talk about personalized medicine. How does that work? And we're going to ask the good doctor about administrative automation, because doctors are clearly overworked, and in my view, they're actually underpaid. So when we talk about AI, in medicine, it's one of these things where there's 2 sides to it, right? Everyone is experiencing AI from a self-service perspective, from a self-care point of view, and doctors, of course, are experiencing it as practicing part of their day-to-day activity. What's your sense of what AI really is today from a clinical standpoint?
Well, from a clinical standpoint, it's something that's definitely going to help healthcare and physicians, but it's a double-edged sword, as many things are. And just, short, interesting story or just notes. By 2030, there's going to be 18 million worldwide not enough healthcare providers, and there will be 15 million shortage of doctors. And by 2028 in the United States, it's not quite as bad, but there's going to be a couple 100,000 shortage of nurses, healthcare doctors. There's also daily attrition, not daily, I should say, a yearly attrition of 600,000 people leaving healthcare.
Now, why do you think that is? Why are people heading out? I mean, there was the COVID catastrophe, as I like to call it, but what else is causing this sort of exodus from the practice?
I think there's a couple of issues. One is, as you said, COVID, and all it did, the ICU, the deaths in the beginning. It was handled well and poorly on many aspects, as we probably know, and maybe for a future time that can go deeper into that. And also with that, a lot of the doctors and nurses worked long hours and saw a lot of deaths, worked too many shifts, and felt that the administration basically, and also a lot of patients did not appreciate what was being done or seeing what was happening to the people taking care of them. So I think one, it's that burnout, and actually being a radiologist, I was just reading the stats and listening to AJR from 2 years ago. Over a third of radiologists, for example, have burnout. But if you look overall, there's 40 to 45% of physicians are burned out.
AJR is the American Journal of Radiology.
Very good. So, yes, thank you. And so that's part of the other part is that's a lot of young people, I think, and that's important for young people, which I hope they will go into medicine, because we're going to need them, because you and I, as we age, there's not going to be enough people to take care of us. And probably in your own families, trying to get into a doctor appointment or something can be quite difficult.
Oh, yeah.
And so young people are rather wanting to do other things. I think it's modern technology. There's a lot of people who want to go into finance because a lot of people want to get a lot of money now.
Yeah.
Also going to medical school can cost you $100,000-$200,000 a year, depending where you go. So all of a sudden you're coming out with $500,000 maybe of debt.
Yeah.
If your parents can't help you.
Yeah.
So all these things are adding up. Plus, medicine is different than it used to be. It's big corporations now running healthcare organizations. It used to be individual doctors, more patient contact in some ways. Now you're being told how many hours to work and not to see a patient. And I think that's all having an effect.
Yeah. I mean, it's an interesting problem. In Japan, I guess, is the closest example that we have a situation where you have a very aged population, very small percentage of people in medicine, relatively speaking. And I guess the model there is one of automation, right? You're having patients self-report. You're having, in some cases, robots attending to people, just from the standpoint of reminding them of medication and different protocols that they might be engaged in, but also just as companionship. Just sitting there alone in a care facility, hospital room, you're not getting visited every hour. Maybe you're getting visited every couple of hours or few hours. Do you think more of that will happen in the West, or do you think that's just a little too far afield from?
I think you brought up an excellent point. Actually, that was in my notes. I think part of the issue with the whole global medicine and healthcare in general is that we have aging populations. Not enough young people are willing to go into medicine or take care of people. And you're exactly right. This is where AI can maybe help, but like robots, there's already robots in hospitals. I think, like, for example, I know some hospitals where already medications being brought with the robots. So that's all happening, and it's all going to help. But I only see it getting worse. As you know, I think Spain, France, Italy, Japan is probably the worst, but South Korea, a whole bunch of countries are not having enough births. And who's taking care of the elderly? And we're all living 10, 20 years longer.
Right.
The other part of the whole healthcare issue is chronic disease, which whole other topic, but which, 40% of the population is, maybe I'm going off.
No, I think it's good to talk about, let's talk about disease for a moment, because I think you're right. We are living longer, right? Generally speaking.
Yes.
Some might disagree with that in certain areas, certain parts of the world. But from a chronic disease standpoint, are we afflicted with the same things historically, or are we getting new things that have emerged because of the way we live potentially in the West, or is it a combination?
Kevin, I think it's another great question, because I think you kind of hit the nail on the head in a sense. The olden days, I think people, not saying that they're all healthier, but lifestyles were different.
Yeah.
More active. There was more healthy foods. People sat down to meals together.
Yeah.
Nowadays, that's kind of disappeared because of things have changed. And with that, with more, I would say, more money, mother and dad both working, not as much together, McDonald's, fast food, that started in the 50s and the 60s. And a lot of people started loving that. And, RFK Jr., who's talking about some of this stuff. In some ways, he's right about the foods we eat, but we don't talk enough about the lack of exercise, the lack of self-responsibility, in a way.
Yeah.
What has this led to? What you're talking about in chronic diseases now, diabetes, obesity, and even certain cancers now, colon, breast, pancreatic, are coming. Things as lung cancer have decreased because people have learned to stop smoking and realize that smoking causes it. And to your point about chronic disease in here and the world, for example, the Chinese and people in the Middle East have some of the highest diabetes and obesity rates now too, because they want beef.
Yeah.
They want all the same things we want.
Yeah.
So we're slowly all poisoning ourselves. And so we are living longer, but the statistics are that people who try to work out, as you and I try to do, and may hopefully eat halfway as healthy most of the time, except for burgers and occasional French fry.
You eat more fries than me, but
yeah, that's true. I can eat fries all day. Coronary arteries, spazzing out on me. But anyway, so that has changed the whole dynamic now. And so people already in their 50s and 60s, 50s, start getting chronic disease. By the time they're 60, they have osteoarthritis, they have diabetes, they have cardiovascular disease. And good portion of the population, when they're 65 or 70, have at least 2 or 3 chronic diseases.
Yeah.
And
it's
they're
stacked up.
That adds up.
Yeah.
And by the time you get to be that age, it ends up making you somewhat of not an invalid, but less able to do things.
Yeah.
And so you can spend 10, 15 years actually with a morbidity or not being totally healthy, while people who supposedly work out, eat healthy, and genetics is also involved, I should say.
Yeah.
Most of those people live, when they get sick, they usually die within 6 to a year. And by that, I mean they're taken up in the hospital or somebody's taking care of them because they get some disease.
Yeah.
So they live a good life to, let's say, a year before they basically die.
Yeah.
So that has really changed, and it's kind of happening the world over in a lot of ways.
So I think what I hear you saying is the system isn't necessarily set up to handle this more longevous cohort of people that's, they're older, they have this more of these chronic ailments, and maybe they have a different kind of care than somebody who's just going to hit the hospital maybe for a week or two, pass on potentially.
That's exactly, and I think that's the problem still with modern medicine in a lot of ways, and I think we are trying to change that, is that there is preventative medicine, but I think it's the lesser of the two, where we usually end up treating people after they get sick.
Yeah.
Or there's a couple of physicians out there who actually argue too that we don't do enough to really track people's health. In other words, let's say with diabetes, for example, you can do hemoglobin A1C or glucose, and you have the normal if you get your own blood test done, if it's below.
Oh yeah, how much I love that.
Yeah, exactly. And then it says, but you're 90, or then you're 101, or you're 110, you're back to 90, and slowly your hemoglobin goes from your H1C, hemoglobin goes from 5.0 to all of a sudden 5.2, and then back down to 5.5. Anyway, over time, and the doctor says, "Oh, you're fine. It's all within normal limits."
Right.
but there's a creep in medicine, in your health. And physicians are actually mostly overworked now. You can only, as you probably know, go into a physician and you can go in with one complaint in 15 minutes. Anyway, that's what most do. So if you have two, you have to make another appointment. So physicians and patients are limited to what they
And talk about
or
time to talk.
time to talk about. So again, I think you're totally correct. We don't have enough time, and it's only getting worse.
Yeah.
And since the numbers I gave you, 18 million healthcare workers globally by 2030 is projected. It's a real issue. And you were talking about Japan. The Netherlands, for example, had the third best healthcare system in the world, but it's having the same issues. I actually have a friend who's supposed to have heart surgery, and she's been waiting for 2 months now. And also one of my fellow relatives was an ICU nurse in Holland during COVID, did the same thing, and she ended up basically quitting. And they're having the same issue, not enough staffing, trying to get people from outside. There's more than enough beds, but there's nobody to staff the beds. It's a worldwide issue that's only getting worse. And I think, the government is not paying attention in general.
So looking at this bigger question of AI, when AI started out in the healthcare industry, it was sort of a splash. I mean, I think back to the current administration, and there was a big meeting. I think it was on the White House lawn. You had Sam Altman from OpenAI, and Oracle, Larry Ellison, Donald Trump, et cetera, kind of all talking or painting this vision about a world where we're going to cure disease, we're going to, make healthcare a more affordable, better experience, if you will, quality of life for everyone, as one of the key tenets of AI. And I guess I think that from an industry insider point of view, it's wonderful to put the best possible light on things, but I wonder if maybe the expectations were elevated a little bit too much, in that regard. When you look at other technologies that have come along, particularly pharmacological technologies, they seem to have made impacts. What's your perspective on really where the value of AI might be from a starting point?
I think from a starting point, definitely, and that's the closest thing that I can relate to right now. For example, radiology. Radiology, I think AI has been really helpful. I'm getting got actually a text today from Doctor Imkamp. Are you available to work at this hospital? I'm getting those constantly because there's a shortage of radiologists. There's more and more exams being done. Radiology, believe it or not, is the cornerstone basically of medicine. Almost no clinician
admit that.
Or is willing to do, especially in emergency room, that they need an MRI, a CT, a plain film, an ultrasound, a nuclear medicine study, a mammogram. And the radiologist is kind of at the center of that, and the radiologist. And that means that the radiologist is reading more and more studies every day. Back in the old days, you'd read 50 to 75 studies a day, let's say, an hour. There's all kinds of different. Now people are pushing 100, 125.
Right.
And that's leading to the burnout, to the stress, to missed cases, to malpractice suits. So what is AI doing? Well, for example, in radiology, AI lung screening for lung cancer, especially in smokers. It's a horror show when you have to go through a CT of the chest and with 100 images and different views and try to pick out 2, 3, 4, 5 millimeter lesion and see if that's a blood vessel, is it a new lesion, and somebody who's got numerous, or is it a calcified lesion because he lives in Arizona, he's got coccidioidosis or whatever. So there, it has been proven that it's more effective in helping diagnose by 25%, leading to the radiologist seeing a lesion, so helping with AI, that's the radiologist, and the 28% better finding of cancers. So there, it's a definite help in healthcare. So going through, and for example, in the Veterans Administration, or even, the Veterans Administration, because of so many smokers, they started this yearly test. At least I don't think they're still doing it yearly.
Yeah.
To try to do that. But to do that, it's a lot of work, and you need a lot of time. This AI is very good. The same with breast cancer. It has proven very effective for women to find lesions. And the other thing, breast cancer, for the women who are maybe listening to this podcast, women in their 20s and 30s are already being caught with breast cancers. They're asking, usually I think it's about 40, they say should be the first time if there's any history of breast cancer in the family or anything suspicious. They're even going now, well, maybe women somewhere around 25 or 30 shouldn't have first time, because there's an increase in breast cancer amongst women in the younger generations.
Yeah.
So this is all very helpful. Also, AI, as far I think it helps from the administrative side, and maybe scheduling, some of the scheduling that takes time can be done with AI. However, AI makes mistakes.
Yeah. Which can be really stressful if you're a patient and you're feeling maybe, not yourself, and you start to self-diagnose, right? It seems like this is a really big issue. People go onto the internet, or they go onto one of the chatbots, and they begin to ask questions about how come I'm swollen here, or I have this red mark over there, and they're very concerned, and then finally get to the doctor, and then I think there's this this immediate sort of pressure to diagnose this problem. And do you think that is helping the cause? Do you think that helps the doctor, or do you think that actually makes things worse potentially?
Well, you've got nothing but great questions, because they really are. Just saying that they really truly are. I think that's as you say, all these guys, the promise, they've overpromised. There's a lot of these new things, and the promise is that AI, you've got human intelligence generative AI, deep learning AI.
Sure.
All these different types have something to offer. The problem is with the first one, human intelligence, it's a machine learning.
Right.
Then you have generative, which everybody is talking about, which is a really big thing. You can get to humanoid type of intelligence. But the problem in AI is that it's input versus output. Who's looking at the input, at the output? And so for patients and for stakeholders, sorry, physicians, for both.
Sure.
Yeah, exactly. It is that they obviously wanted to succeed, but physicians are, first of all, when they see a patient now, a lot of hospitals already do have algorithms, in essence, that they have to follow. So if you say, I think I've maybe got diabetes, I'm peeing too much or whatever, you get sent into a certain algorithm. And if you mention something else, then other algorithm. And the physician's almost forced to partially go down the path that's in the algorithm.
It's a predefined workflow in essence.
Exactly. Thank you.
Yeah.
And so that's one danger. So that can be good. AI can have so much information that sometimes they can maybe come up with zebras, as we call them. But at the same time, that's why AI will, I think, never replace doctors, is that you still do need the human input. And the realization, and I was watching actually a YouTube piece on something like this, where the thing was from a doctor, a good doctor knows when to say, I don't know, versus the algorithm or what we've learned. And when is a machine ever going to say that?
Right.
An AI machine will probably never say that to you. And that's why if you go into the algorithms, it says so and you don't believe it, you should not believe it. on so that's the stakeholders portion, the physician. The patient also has to believe when he's being told, well, AI is helping, or they've gone to AI, that what the doctor is using and the machine, that tool, that's really true? Is this working? They have to believe the AI. Or are they being fed a story by the AI? So the patients on one hand like it in the sense when you have now dermatological video type of things where you can go sit like what we're doing here, sit in front of a camera, take a picture, and you can shoot. The image can be taken, and then AI can look at it and think, well, you have this and this, and we can recommend you. So that's helpful if you're in a rural area, and AI there is helping out. But AI, the black box, what they also schizophrenia or psychosis, right, which some machine, but as you know, I'm sure as you know, it does happen. So that's part of the issue. And the other issue is the medical legal. So what if a physician doesn't listen to what the AI says? For example, take radiology again. You have a certain bleed in your brain, or somebody goes with a headache, and you don't quite understand, or you misread it, or whatever, and
It's a false positive.
a false positive,
Yeah.
Or false negative.
Or
But anyway, somebody gets there's a malpractice suit.
Yeah.
And all of a sudden, well, the AI caught it. How come you didn't catch it?
Right.
Juries now are starting to believe if the AI says it was there, that the doctor must be wrong. So there's a big medical legal issue now with AI in healthcare. Who's responsible? Is it the healthcare organization? Is it the physician? Is it the AI machine, or is the maker from the AI machine? Because the AI people who make these machines, as I said, the input versus the output, who's doing that? Are you guaranteeing that there will be no errors in your system?
Right. It's very interesting the way that, when you look at the models that AI uses from the standpoint of development, our models are very much about pleasing the end user. So if you're interested in, being more funny, for example, AI will tell you things that are humorous, right? And they'll continue to reinforce those things. And as you choose more and more of those things, it reinforces them. Kind of like with shopping, right? If you're inclined to buy a certain type of house, let's say you like modern, you like retro,
Right,
modern, you'll be sort of seeing an abundance of retro modern sort of opportunities come your way. And I think that's anathema to the problem of medicine. Right? It doesn't matter that you're reinforcing how I feel about your problem, right? What matters is I get to the bottom of what is ailing.
right.
However, whatever way I've got to do that as a doctor, right? There's some art there. Tell me about that.
Well,
how do you get people to really give you what you need to make that diagnosis?
Well, first of all, I think you have to have trust. But if you're seeing a patient for the first time
for 15 minutes,
15 minutes, it can be difficult.
Right.
And it can also be, depends. I mean, if you're in an emergency situation, people come into the emergency room and, they can't breathe, or they've been bitten, or something horrible's happened, or they're feeling like they're having a heart attack.
Right.
They're going to want you'll ask them questions, and most of them are going to answer. But there's other issues, like, for example, one issue with doctors and patients don't like to talk about, when you talk about an intake, with whomever it is, if you're a general practitioner, internist, besides all the things, all this sexual histories.
Yeah.
Nobody
wants to talk
Nobody
about
wants to talk about it.
Right.
But half the population has issues with it.
Right.
But again, and that's something where you have to have trust, but it's also you as a physician have to feel comfortable with certain issues. And I think the problem is a good doctor can you have to kind of be able to read people. And
Yeah.
you probably have to your profession. I think in every profession, the person you're sitting across from when you're trying to do your job and trying to get something done, you try to figure out what that person wants or needs, or if they're happy or making faces or they're totally getting lost. That's important. I think also feeling empathy for the patient. And I think one complaint from a lot of people is that doctors don't sometimes have empathy.
Yeah.
And if you don't have empathy, then it's an issue. Another issue related to AI is, as you say, is the input. And by that I mean that's people from different strata, wealthy versus minorities, Black, Asian. AI, a lot of models are run on a majority, like on white people. It's like drug tests were done.
Yeah. The consensus does not look like the majority.
Exactly.
Yeah.
And and that's, for example, a lot of test medicines studies were done on men, but not on women.
Right.
Or if you have osteoporosis, the studies have been done on women, but not on men.
Yeah. So you have this built-in bias, which the models always have bias. There's no way really around that in many respects, even with training. But that's a wonderful point.
Yeah, no, but exactly. So that's bias. It's a big problem in AI, and in developing more AI to be helping all people in healthcare, and not just within young people, older people, people around the world. Another issue with AI, for example, is AI works better in adults or in large groups of people where you have certain disease types or genetic genomes that have been discovered. And for example, with pediatrics, AI doesn't work as well because there's not enough cohorts of enough people that have been studied.
Not a corpus of information that's
exactly
robust enough
robust enough accurate. That AI can be accurate.
Yeah. I guess I worry about two things right now. I'll ask you these two interesting questions. So when you go to the doctor, when I go to the doctor,
Right.
Who's in charge? Is the doctor in charge or is somebody else in charge?
That's also a good question. And I think part of it is partially the doctor's in charge, but partially he's not. Because you know, as a doctor, for example, what the patient has, and the patient needs such a treatment.
Right.
Now, with healthcare nowadays and insurance companies and all the middle people, so sometimes they're a physician assistant, sometimes they're a nurse. We're sitting somewhere in an insurance company, and the doctor's requesting, this psoriasis, for example, dermatologist, a certain drug. There's this and that drug. Well, we've already tried that drug. So the doctor has to go back and write another letter to the company. And so it could take two months, 3 months, 4 months before a patient actually gets the medicine that's needed.
If I think about the ecosystem in healthcare, I guess I see 5 major blocks of influences, shall we say, on an outcome, right? You've got the doctor, obviously, he or she,
right,
whatever their practice is and their area of competence. You've got the actual insurance company. You've got the administration of whatever the doctor's affiliated with, whatever that clinic or hospital, et cetera. You've got the pharmacological complex, right? The drug complex,
nightmare,
and everything that they do, right? And then you have the government, right? And then you're not even in the picture yet. You're 6, right? So those are the big blocks, right?
Right. Yeah.
And so even if I'm desperately ill and you know me really well and you diagnosed me properly and you've got me lined up with the right medication, there's a lot of other things that could go wrong before I'm actually able to get the help that I need.
Yeah. So getting to see the right doctor.
Yeah.
And that's part of the thing with HI. Are we going to, AI can maybe help you make a diagnosis quicker so you see the right doctor and get handled. For example, AI in cancer. One thing AI in cancer can help is that cancer patients usually have very thick files and they go through many tests and many labs to see many doctors, and it's spread all over the place.
Right.
AI can consolidate that and make it into a nice summary for physicians. There's what we call tumor board, where you would have a radiologist, oncologist, internal medicine, pharmacologist, oncologist, and used to have to do those, and you would have to take hours and time to bring this all together. AI can help that now, and the thing is that with that, you can make the care better of the patient. You can personalize personalized medicine with AI. That's
Right.
one thing that AI can do.
Right.
The
In
other,
15 minutes?
probably in 15 minutes.
Okay.
Yeah, they have a computer and then they can put it all together in 15 minutes. What would take us days.
Absolutely. I think what I'm hearing people say, there's a group of people probably like me, I guess. We all know ourselves, I guess. I don't know.
Right.
Other people, but when I'm not feeling well, I want to know what's wrong with me and I want to fix it. Right. And I don't want to sort of diagnose myself. I really think that it's more about, I have a pain.
Right.
Why do I have this pain? And
Right.
can you, no, I didn't need to know why. I just want to know what it is and what are we going to do about it so that
Right.
I can go do what I like to do, which is
Exactly.
not be sick. Right.
Right.
So I want AI my way, right? I want whatever, like if I'm going to interact with the computer, I want my doctor to know.
Right.
Yesterday at 2:00 in the morning, you go into the doctor, I say, well, what time did this start? Well, I don't know. I mean, I started to feel bad around 2:00. Maybe it was 3, maybe it was in the evening. I'm not, you don't remember, right? People are
Right.
imperfect.
Yeah.
We don't remember everything
Right.
necessarily, but we know when we hurt, right? We
Right.
know how, we want to feel better.
I think that's what most people would like. I do think that, again, for preventative, I think we need to be more involved with our patients. I think we need to give the patient a basis from why are they getting sick? Why are you not feeling well? Try to really not get into their head in a sense.
Right.
From your lifestyle. Why are you doing this? Why are you doing that? Or why aren't you doing it? AI, I think, definitely has a place. I don't think it will. People are saying it will replace doctors, or that's can all the. I don't think so. I don't think it. Maybe there's going to be a robot who's going to be sitting across from you. Or, I'm a robot sitting across, and I'm going to ask you questions, and
Right.
I'm going to have tactile fingers. I can
probe you and prod you and
yes,
see if
prod
there
you,
really is anything
exactly.
wrong. Okay.
And then come up with, maybe 10 years down the road. I know in China and in Japan, they have robots that do things already. And
Yeah.
so I'm not saying that it's not going to happen, but without human inputs at the beginning and at the ends, things are going to go wrong. Will AI help in the healthcare shortage? I think it will, but I think we need to be aware of what we're letting loose. We want to make healthcare available to everybody, cost efficient and affordable, and trying to make it something that's worldwide. And if AI can do that, then I think it's a great invention. And I hope for all the young people, I hope that young people will go into medicine.
Yeah.
Whether it be a doctor, a physical therapist, an x-ray tech, a sonographer,
lots of opportunities.
There's lots of opportunities. Actually, right now, the best opportunities for you are in healthcare.
My industry has got to be much more responsible with our messaging, number one, but also the types of capabilities that we're programming. AI should be for us. It should be AI our way. It shouldn't be AI the tech company's way. It shouldn't be AI based upon the way that business, wants to impose it on everybody else or organization, the government, what have you. It should be for the people. The people should have a say in at least applying AI to their own private information.
Well, that's another interesting point that you bring up then, because that's the issue right now about who controls AI, and who's going to do it. It's going to be the government, it's going to be the companies, it's going to be states. And as you know, the European Union, for example, wants to make rules and regulations for AI. And actually one of the inventors of AI, the Brit, I forget his name, but who actually was greatly for AI, now saying, hey, we got to slow down, wait a minute, we got to slow down. Right. Is saying that we need this. But as you know, the United States government, or the present government, and Cook and all the tech bros are saying, we don't, no, because we have to win this race with China. It's the way we're being sold. And maybe
Maybe
I'm not
that's
smart
true.
enough. Maybe that's true. I don't know what
Right.
goes on behind the scenes in those dark
Right.
rooms in governments everywhere and all the spy stuff. I'm sure a lot of it's true, and we can only hear 50% of the truth.
Right.
So maybe we do need to, but again, there's so many things throughout history that have been invented. It was gunpowder,
Sure.
also nuclear fission. Oppenheimer started talking about it. All of a sudden, what have I created? What I've let loose on society. I think we're kind of dealing with the same thing here.
Yeah.
And there's a book, I think it's called 2027, where supposedly two AI tech giants in the United States and China
Using it
decide to start a nuclear war, or they take over the societies completely.
Right.
They are able to shut down electricity, defense, banks. They control what happens and doesn't happen. I mean, whether that's, and there are some people saying that could actually happen if we really get this generative AI or Anthropic or what's going on. And I'm not smart enough to know that. So you're probably know
I
more
think
about
it's
it
so
than I
much.
do.
I think the biggest thing that is happening now with this current turn of technology is very unique in history, is the depth with which everyone is affected, everyone has information about. I've never seen a generation of people or a example of a technology that goes from top to bottom. The older people, the younger people, everybody has a really good sense of what is happening. And I think partly because it's accessible, right? This computer's not in a back room somewhere where you can only get in with a badge.
Yeah, like, right.
You know,
exactly.
it's all in front of us, right? We're using it on our phones, we're using it on our tablets, whatever access method we're using. But it's dangerous too, because I think it represents a sort of salve, if you will, sort of a numbing effect on people. They think that it's your friendly neighborhood tech company sort of, you know, helping everyone have a better life.
Right.
But indeed, sometimes that's not the case. That's not really the objective. And I can tell you that as an insider, right?
Yeah, right.
I think though that for you as a doctor, as someone who is really in the business of helping people, you know, that's something that has to be translated or transferred into the models if we're really going to help the medical community.
Yeah, because I think the danger here is that indeed the AI ends up taking over and taking the human aspect out of it and making the private equity firms or the people who can make money out of this. And it's already actually, I just read an article about that too. There was actually something like that happened in AI where a couple of people were being denied their care because the AI model said so. And 2 or 3 months later, they finally got the care. And there's now lawsuits because of that.
Yeah, because of the delay.
Because of the delay. And the delay could be death.
Yeah, I could have passed away. I've had a horrible quality of life this entire time. I'm
Exactly.
sitting here waiting.
And your other point too about, I think AI and what we're dealing with now, computers, and it started with some BlackBerry or Microsoft, and then now the iPhones, the tablets, and all this. It's so much different from, when you had the sword or the copper, you could knock somebody's head off.
Or the train.
Or the train. But you could, somebody, but only a few people could do that to each other. Then you've got gunpowder, and all of a sudden, all these big forts that were, you could blow holes into them. Okay, blow up your fort. But it happened to a small amount of people. It didn't blow up. Then we got nuclear fission. Now you can blow up
whole town,
the whole city, maybe. Yeah. And now we've created AI, as you say, which AI and computers that can do things that are going to be in every part of society, in every nation.
Right.
And again, is this going to be only for the wealthy nations? What's going to happen to the people in Africa and South America? Okay, where are they going to get them? Are they going to be allowed to have this? Is there an equity in healthcare and wealth going to get bigger? Because are the guys over here and in Europe willing to share with the people in South America, South Africa, who supposedly a lot of people, they don't want to help themselves, so we're not going to help them either.
Right.
I mean, it's, so I mean, the inequity, this could really turn history upside down. This is a scientific I had a great course back in my sophomore year at the University of Washington, science or the history of science. It's fascinating. And it's going to be interesting if somebody's going to be writing a book about the last 50 years and including this epic.
This time moment in history.
And what happens with this. And I'm assuming you're probably going to be around, so hopefully you get to maybe see what this all leads to. I'm not sure if I'm going to see it all, but I think it's going to be a momental game changer. I think AI is
for
game
the
changer
positive.
for the positive, and maybe not. Hopefully for the positive. But we'll stick with being optimistic.
Fair assessment.
Oh yeah.
So thank you, Evert, for your
You're
time
welcome.
today. I really appreciate it. And I hope that
Pleasure.
everyone is getting some insight that they wouldn't have otherwise been able to get. I hope that we've motivated some young people to think about studying medicine. We need all the help we're going to need in the future. And I hope that if you're an IT professional, you're spending some time thinking long and hard about what our obligation is to the rest of society. Have a great one.